Okay, abdominal emergencies. I hate these things. Abdominal emergencies. Let's get after it, guys. You'll have a lot of patients that tell you they have abdominal pain. And it can be any number of things in there. It's very hard to diagnose. So we're going to treat everybody like they have a serious emergency and then just move on from there. You're going to learn how to assess a patient, how to recognize the things that you should be frightened about and the things not to be. Look briefly at the anatomy and physiology. I'm going to want you to read this in your textbook. Some of it's a little bit complicated. You just have to sit and kind of work it through your brains until it makes sense to you. We're going to look at care and treatment for a patient with abdominal pain. Let's see. Thorough patient assessment is going to be the key to treat your abdominal pain patients. Because as you know, some abdominal pain can be life-threatening. It can kill your patient very rapidly. We've talked about one specifically that can kill your patient within a matter of minutes. Can you think of what that would be? Yeah, AAA. What's that? Abdominal aortic aneurysm. Right. What would be the signs and symptoms of that? What would they say? They have what? Abdominal pain, yeah, but where else is it present? Lots of time back or flank pain. What would be the other, how about vital signs? The what? You may palpate a pulsating mass. What about their blood pressure? Usually it's going to be quite low. Yeah, they bottom out really quick. Okay, several systems run through the abdomen. You got the digestive system, the reproductive system's down there. What else? The endocrine system, and I'm not sure what they mean by regulatory, but unless we're talking about endocrine. Okay, you need to be vaguely familiar or somewhat familiar with the different organs in the body. I'm not going to, give you a little fill in the blank, point to it, and that kind of stuff, but you do need to be familiar with the difference between the solid organs and the hollow organs. A hollow organ is going to be something that stuff kind of moves through, that it can fill up. Like, for instance, the bladder. Do you think that's a hollow organ or a solid organ? Some days it feels really solid when I don't let you guys out for a break, right? So that's going to be the difference between a solid organ and a hollow organ. The stomach is hollow, of course. You know, the intestines are hollow. That doesn't mean they're empty, right? It just means stuff moves through there. They can flatten out and stuff. Whereas your solid organs, kidneys are solid. Fluid does move through there, but if you cut open a kidney, there's a lot of mass in there. You know, the filtration parts of that. The liver, extremely vascular, which is, a lot of fluid in there. But if you open it up, it looks like a piece of meat. It looks like some really delicious steak going on in there. So, do what? Does it make you hungry? So anyway, these are going to be your solid organs, and they're going to respond differently, and they're going to react differently. When you have pain, it's going to point to one of these or the other sometimes. So they're going to feel pain differently. So we'll kind of talk about that. Organs in the abdomen, we're going to look at the peritoneum. That's actually the lining of the abdominal cavity. And there's also peritoneal tissue that covers each one of the organs. Now we also have the parietal and the visceral. The parietal peritoneum, that's going to be the lining that actually lines the outside, the abdominal cavity, whereas the visceral is the part that covers each organ. Does that make sense? Not really. Why are you making me learn this? Okay, the parietal is going to be the outside covering, right? The visceral is going to be that actually touches the organ. So that's just a tissue, a thin layer of tissue that kind of encapsulates your organs and the inside of the abdominal cavity. Now we have a small amount of peritoneal fluid, because we're talking about the peritoneum, right? It's the inside of the abdominal cavity. So we've got peritoneal fluid, and that's a lubrication. When you consider you've got coverings over all those organs, and as you're moving around and doing stuff, they have to slide by each other. As you take a breath and your diaphragm drops down, it pushes your liver down and pushes everything down. They have to slide, so you're going to need that lubrication. So all of that's important. You remember we were talking about pleurisy a few days ago? What's pleurisy? Yep. Oh, yeah. It's the inflammation of the pleural tissue, which lines the lungs. And as you take a deep breath, if you've got an inflammation there, it hurts as that tissue tries to slide and move within the chest cavity. Same thing in the peritoneum or in the abdominal cavity. If you get inflammation in any of these tissues, in the parietal peritoneum or the visceral peritoneum, then when they go to move, they hurt because they have that irritation. So those are some of the causes of pain in the abdomen. Let's see. The organs, most of our abdominal organs lie in the abdominal cavity. Some will actually lie in what we call the retroperitoneal space, which is actually towards the back. Like your kidneys, for example. Those are retroperitoneal. Retro, you know what retro means, right? You know, let's go retro. You know, I'll like frizz my hair up and look like a country music singer. That's retro. So anyway, retroperitoneal means it's back somewhere. It came before. So it's in the back. The bladder and part of the rectum would be considered retroperitoneal also. All right, how are we doing so far? Okay, here's a few organs in here. And this breaks down the boundary of the peritoneal lining. It's going to be right here. So if it's behind that, then it's going to be retroperitoneal. Y'all can bring these pictures up anytime and look at them. Okay, for us, we're going to divide the abdomen into 4 quadrants, or quadrants, if you will, which happen to be of which is 4. 4 quadrants. As you go up in the program, we divide them up, into more different, more spaces. But for us, it's going to be 4. Right upper quadrant, see the little RUQ? Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. And they all rotate around the umbilicus, which is also known as your what? Our navel, our belly button. That's right. See where the diaphragm is right here? Is he inhaling or exhaling? That would be exhaling, that's right. If he was inhaling, it would be flat and lay across there. The epigastric area also is just kind of right through here. Abdominal pain or discomfort. All right, now here's where it starts to get tricky. Here's where you're going to make some little note cards and make a little note to self. Visceral pain. Where is the visceral peritoneum? What does the visceral tissue do? The visceral lining. It's going to what? Line the organs, right? So it's going to be right on the organs. In the visceral peritoneum, there's not a lot of nerve endings on there. So when a patient has an inflammation in the visceral part, then it's going to be a very dull and diffuse pain. So it's hard for them to say, oh, it hurts right here, because it's diffuse and kind of dull. They'll say that it aches. Oh, my stomach aches. Really? Also, you've heard of kids that have colic, right? You know, they're just crampy. It just feels like really bad. Nobody knows what causes it. And it's also intermittent. That's what visceral pain presents like. It's intermittent. It's achy, crampy. I can't tell you where it really hurts. It just kind of hurts all over. When you look at, of course, the visceral is what covers each organ. But then remember we talked about the hollow organs and the solid organs. So with our hollow organs, and what would be a couple of examples of hollow organs? The what? The stomach, so your intestines, the bladder. Yeah, those are hollow organs. And they are what usually gets real colicky, meaning it's intermittent, it comes and goes. With your solid organs, usually the pain is more persistent. So if you're trying to determine, if it's, pain in the liver, or if it's, the ovaries or something, you might look, is it a solid or is it hollow? Is it intermittent pain or is it constant pain? So that may help lead you down a pathway. But for us, we're going to treat it all the same, so it doesn't really matter, but you sound a little bit more intelligent if you can pinpoint something. Okay, parietal pain. With parietal pain, it's usually very specific. The patient can point to it and say, it hurts right here. It's very specific. Generally speaking, they'll say it's a sharp pain, different than the visceral pain, which is very diffuse. It's hard to pinpoint. So it's usually very severe, it's constant, and they can localize it. So here, where is the parietal? Where's that? Yep. It covers It's around the lining of the abdomen. It doesn't cover each organ. It lines the inside of the abdomen. Okay, let's talk about referred pain. Referred pain is going to be a sensation of pain at some place other than the where the pain is generated from. We have a lot of nervous system that moves through the abdominal cavity, and sometimes there's crossing over of things, call those dermatomes. And as some pathways get really close to others, and particularly if you have a diffuse pain, sometimes it'll get picked up on the wrong nerve track, and it will have referred pain. So referred pain is a pain sensation that's transmitted from one system to another. Tearing pain, we talked about this. When do we have tearing pain? The only time that a patient will tell you it's tearing pain, it's going to be the AAA. Is that what you said? Yeah, with the AAA, the sensation will be a tearing pain, and that's just what they say. That's going to be indicative of an aneurysm, usually, in the abdomen. And when it ruptures, it's very, very bad. Now, the aorta, as it moves through the abdomen, it's right on the cusp there, but it's retroperitoneal. That's why they'll say it's back pain or flank pain, because it is retroperitoneal. But it refers more towards the back because of that. So that's tearing pain. Abdominal conditions, again, we already saw that one. Is that right? Yeah, good for you. Appendicitis. Nick had appendicitis last week. Nick, did I tell you all that? Thursday? Yeah, Friday morning. Yeah, he had appendicitis. Had to go get surgery and all that stuff. It was kind of funny though. I was asking him yesterday. I said, "Well, what were your signs and symptoms?" He said, "Well, my stomach, it just hurt really, really bad, and I felt really sick and nauseated, and I couldn't eat anything." I said, "Well, did you think appendicitis?" And he goes, "No." But his wife's a nurse too. I said, "Well, did your wife pick up on that?" She said, "No, neither one of us thought of that." I said, "Well, probably in the right field then." Not really, I'm just teasing. But as EMS people, we should recognize appendicitis. Very frequently accompanies constipation. If you've got a patient that's chronically constipated, they run a higher risk of appendicitis. But the signs and symptoms, persistent left lower quadrant pain, and it will centralize around the umbilicus after a little while. If it ruptures, which is bad, people can die if your appendix ruptures. That would be sudden, severe, increased pain, and you're going to get to the hospital really, really quick. But yeah, they'll usually feel nauseated, sick. It almost feels like a flu, but severe abdominal pain. And you just run them on up to the ER. Peritonitis, you can figure out what that means. Inflammation of the peritoneum. And we know where the peritoneum is, right? Okay, good. Usually this is caused by some kind of leakage through the intestines. Some type of fluid has escaped from one of your hollow organs, where it's going to dump some matter in there that doesn't need to be dumped into the abdomen. So it will cause some irritation in there. Usually that stuff is acidic, and that's very irritating. Irritation causes involuntary contraction of the abdominal muscles. So when you have that pain and that irritation in the peritoneum, it causes you to tighten up. So once you start tightening up, what's the body position? Yeah. So most of your abdominal pain patients are going to feel most comfortable if they're in a fetal position. Yeah, of course. I can do it. I just couldn't think of it. Fetal position. If you palpate the abdomen, it's going to feel very rigid because their muscles are contracted. Cholecystitis, you know what that is? Inflammation of the gallbladder. Who's had their gallbladder removed? Your mom? Nick's had his gallbladder out too. I was like, oh my gosh, he's like in his 20s and he's had everything. But anyway, he hasn't had everything. He hasn't had a baby. But inflammation of the gallbladder, cholecystitis. Which gender do we see gallbladder emergencies with more commonly? Women, yeah. If I got that up there, I don't know. But I'll tell you how you remember. G is for girls. So gallbladder we see more commonly with women, but not always. A blockage, gallstones actually will form in the gallbladder. It's never good. But typically you'll get this call because somebody's got severe indigestion. They've eaten a meal that had a lot of fatty and fried foods in it. Usually within about 30 minutes after eating, they're like doubled over in pain. As I said, it's mostly women in that middle age, 30 to 50 is just most common. The signs and symptoms, sharp upper gastric pain. Oftentimes though, they'll have referred pain to the shoulder, usually the right shoulder and the right scapula, because of those dermatomes. So if you've got somebody and they've got, severe indigestion, sharp pain in the gut, and they say they've got shoulder pain, then you're going, have you ever had gallstones before? Well, you're having them now. Okay, pancreatitis. You can figure that one out, right? Inflammation of the pancreas. We see this very commonly with alcohol abuse. It just really tears up your pancreas. Signs and symptoms, epigastric pain, also frequently referred to the shoulder. So you'll be looking for history here. Patients may have had a bout of pancreatitis before, but if they've got a history of chronic alcohol abuse, then you're going to think pancreatitis. GI bleeding, that's going to be your favorite call. You don't even have to worry about recognizing a GI bleed. You're going to be all over that one. Sometimes patients are not aware that they have a GI bleed. It can be such a slow bleed that your only signs and symptoms are going to be shock. They're very weak. Their blood pressure is very low for no obvious reason, and it may be a very slow GI bleed. Or, and it could be an acute bleed, where you actually will see bleeding from the rectum, or they may be throwing up blood, that kind of thing. It may be painless. They don't feel anything. They just feel very weak and they're hypotensive. They may see blood somewhere along the way. Now, if it's associated with a gastric ulcer where they've actually got a hole or a compromise in the GI system, and then you get some of those fluids to leak out. Remember we were talking about how irritating that is because it's very high acid content, and it'll cause inflammation of the peritoneum. So once that happens, it's going to be severely painful, and they develop peritonitis from that. So it's never good, never good. You can have an upper GI bleed or a lower GI bleed. The gastrointestinal system is very long. I mean, if you took that out and laid it out, it'd probably go from one end of the building to the other. It's quite long. So if it's an upper GI bleed, I don't know if we talked about this before or not. Think about if something starts bleeding, very high up here. How long is it going to take for it to get out? It takes a long time. And that blood dies and it gets real grody, and then finally when it's passed, it's going to be very dark, almost like coffee grounds, because little clots form in there and it gets real grainy, and it's pretty nasty. So you'll see that. Did that gross you out? Did you eat any, Rodney? Yeah, it smells.
That's a special smell.
Yeah. Yeah, you walk into the house, it smells so bad. You just hope that whatever your gross out factor is, you hope it's not vomit. You hope it's like snot or something. Because you walk in there and you smell that, and if you've got a weak stomach, you're going to be heaving it. It's pretty bad. So anyway, your upper GI bleeds, they may have a peptic ulcer, something that chews away the lining of the stomach or the upper intestinal system. We also see it with a varices. I don't think we really talk about an esophageal varices in here so much. Esophageal varices, you know where the esophagus is, right? Well, varices really is like an aneurysm, but it's going to be in the esophagus. And the esophagus is it's very vascular. There's a lot of blood there. So if you get this varices that forms like an aneurysm and it breaks or it ruptures, that patient's going to lose a lot of blood very quickly. They're usually coughing it up, they're swallowing it, they choke on it. If it's a slow bleed, then it's going to move down through the gastric system, or through the gastrointestinal system. Now, a lower GI bleed looks a little bit different. Usually you're going to see fresher blood because it's much closer to the exit there. We see this usually as a result of diverticulitis. Diverticulitis is when the colon actually kind of telescopes. It kind of will slide up in one another, and then it starts making little pockets, and little things will get caught in there and then get infected. GIs, most commonly we don't see it in people under 40, and as they get older we have a greatly increased incidence of it. Signs and symptoms: dark colored stools, also called melena, tarry stools. My students last semester love this. Hematochezia, that's going to be passing fresh blood. You know, somebody might look like a hemorrhoid or something, but that's hematochezia. Frank blood is going to be blood that's from the rectum, usually like a hemorrhoid or something like that. Now, your patient may be vomiting something that looks like coffee grounds. They may pass something through the rectum that looks like coffee grounds. That's going to be dead, dried, crunched up blood. Pain, it may be completely painless, or it may be very severe pain. You know, it's going to run the spectrum. I define frank as obviously visible. Frank blood is something you're going to be able to see. It's, you know, big bad red blood. It's frank bleeding. Okay, whew, got off of that, huh? AAA, we've talked about this several times. It's going to be a weakening of the inner lining of the aorta. Typically, we're going to see it in the abdomen. An aortic aneurysm could occur in the chest, but we see it much more commonly in the abdomen. It starts out as a dissection, and then it ruptures. It may rupture from there. But you'll get a bulging, just like you would have an aneurysm in the brain. It's going to be a bulging there. And as it continues to fill with blood, it's going to continue to get larger. This is when, as it grows, you may palpate that pulsating mass where it's just getting larger. I mean, it can get quite large in there, and then eventually it will probably rupture. Signs and symptoms, we mentioned this before, they're going to say they have tearing abdominal pain. Pain that radiates to the back. You may be able to palpate a pulsating mass. Pulsating because that pulse is generated from the heart. You'll be able to feel that. And you're only going to feel that in the presence of an aneurysm. And it's got to be a pretty good size aneurysm in order for you to feel that. And another thing you'll check for is the pulses. You know, normally we're going to have equal pedal pulses. In this case, one may be absent or very weak, and the other one's not. Signs that it's ruptured, usually it's going to be a sudden severe increase in pain. I mean, pretty quick. Blood pressure drops out. They will, because it's the aorta, they will probably exsanguinate. They will hemorrhage. These, we don't have very good outcomes from these. The nice thing is it's pretty quick. Hernia, y'all know what a hernia is, right? Anybody in here had one? You know somebody's had one? Sure. It's a hole in the abdominal wall, because we're talking about abdominal injuries. A hole in the abdominal wall that allows some part, tissue or organ to extrude through that. And if it may get through there and then it gets strangled off and it can't get back. That can be really serious. If you got part of your intestine that actually goes through this hernia and then it gets strangulated, that can actually kill your patient. So hernias can be pretty serious. It's often precipitated or caused by heavy lifting, you know, that whole grunting thing. Often will require surgical repair. Signs and symptoms: an acute onset of abdominal pain. They'll usually report that they were doing some type of lifting or heavy exertion. You may be able to palpate it. You know, as it's split open and then something slides through there, you may be able to palpate that through the abdominal wall. Sometimes you may feel it in the groin area as you herniate down there. Okay, renal colic. What's renal? That refers to the kidneys, that's right. You can have kidney stones. They travel through the ureter very painful. Y'all ever know anybody that's had a kidney stone?
Yeah.
Oh, not good, huh? They can range from pretty mild that you just feel it and then it passes to one that doesn't pass because it's so large and they're going to have to perform an intervention. The signs and symptoms, it can be severely painful, Cramping, intermittent pain, flank, back, often referred pain. It hurts so bad they are nauseated and they may vomit on you. So this is an emergency. Kidney stones need to be treated right away. If it's really large and actually blocks the ureter, then they're not urinating. They're not getting rid of all those toxins. So it's very serious. Cardiac involvement in abdominal pain. Remember I mentioned this earlier that sometimes abdominal pain is a result of a cardiac issue. Pain from MI can produce nausea and vomiting. They can have an MI that presents with just epigastric pain. It can feel like indigestion. So anytime you have a patient that reports pain in the epigastric, upper part of the abdomen, go ahead and get the rest of that history because it may be a cardiac cause rather than an abdominal cause. I did mention esophageal varices. Is that in your book? Is esophageal varices in there? Do y'all remember? Did you read that? I'm thinking that it's not. I added this. An esophageal varices, as I mentioned before, is going to be a bulging or a weakening in the blood vessels like an aneurysm in the esophagus. You're going to find this typically in alcoholics. They're usually very heavy drinkers. It just erodes the esophagus. These patients often will have liver disease as a consequence of being alcoholics. And because of the alcoholism also leads to renal hypertension, which then also will back this up and cause bleeding through there. Increased pressure in the venous blood supply around the liver, the stomach, and the esophagus. If you get a patient with a ruptured esophageal varices, you better run. Has anybody ever seen one of those?
Yep, 19-year-old.
19?
19.
Whoa. I've seen it in several kind of middle-aged people, but not in teenager.
19 years
Ooh,
old.
they got after that drinking early, didn't
Oh,
they?
yeah. Stayed on the floor for 9 or 10 months. It was bad.
It's real bad. I mean, by the time you've got esophageal varices, you're not going to outlive this one. But this ruptures, and there's so much bleeding that if they just survive not suffocating on the blood, they're going to bleed to death. It's horrible, and blood's everywhere. I mean, you walk in, it looks like they've slayed some pigs in there. Intestinal obstruction, this is never good either. An intestinal obstruction, anything, an impaction, anything that's going to impact the bowels, I need to go home, can interfere with the movement, through the GI system, very bad. So with the small intestines, usually you've got some kind of adhesions where it's almost like scar tissue, or maybe a result of some kind of hernia, something of that sort. With your large intestines, we're looking at fecal impaction, tumors, that sort of thing. I'm not sure what overloading is unless you just eat too much and it just like fills. I don't know. But patients who are constipated run a much greater risk of this happening. But you can become septic very easily because there's a reason that stuff is moving through the gastrointestinal system. It's waste products. It's toxic. It needs to move on out. The longer it stays in there, the more toxic it becomes. If it irritates the lining, then you may get a breakthrough there, and you're going to end up with peritonitis and that sort of thing. Generally, we're going to see this with patients over 50. The older you get, the more likely it's going to occur. When you think about how all the systems of the body break down, peristalsis slows down. Your older patients sometimes have trouble swallowing because you just can't get that peristaltic action. Same thing occurs in the intestines. You got to have that peristaltic action moving everything, and it'll just kind of slow down. It's just very ineffectual, and so they're going to get fecal impactions and things of that sort. It's extremely unpleasant. Care for patients with abdominal pain. We're going to treat them all like they're fixing to die because sometimes they are and we can't tell the difference. It could be a 19-year-old with an esophageal varices. That's a shocker. So recognize that there are a lot of causes of abdominal pain, and knowing that it can be something that's relatively minor to something that can kill your patient, in a matter of minutes. You got to treat all abdominal pain like it's a really big deal. You got to get a good history. You can't look at somebody's abdomen and go, oh yeah, I can see that's whatever it is, because you can't. You can palpate it, but outside of feeling a pulsating mass, you can't really be sure what's going on in there. So you got to get a good history, do a good physical exam, and you got to treat them and look for any serious life-threatening conditions. Okay, you're seeing size up. Make sure you're ready for that bloodborne pathogens thing, because these people vomit and they bleed and they defecate and they do things that you're not going to like. Now, this is kind of funny, but let's use your nose on here. I hate to smell anything bad. I can take just about anything, but I don't want to smell anything bad. But your nose often is going to tell you what's going on with your patient. Remember we were talking the other day about DKA? What are you going to smell? Yeah, that sweet kind of fruity ketone smell. If you've got somebody with a GI bleed, what's it going to smell like? The worst thing you've ever smelled in your life. But you're going to walk in, you're going to smell it, and you're going to know we've got a serious GI thing here, and move from there. Now, on your ambulances, you may have, I know we used to carry Vicks Vapor Rub, not because anybody needed it on their chest, but you can put that right up here on your upper lip, and it just kind of kills some smell. So carry that in your airway bag, because your airway may need it.
I have to sleep every night without my Vicks.
Yeah, okay.
I cannot put this down.
Can't sleep without my Vicks. Okay. All right, your primary assessment. Remember the parts of your primary assessment? What's the first part of your primary assessment? Do what? General impression. No, before that. This is fakes you off. Mental status. Chief complaint. Now we've got our ABCs, right? Okay. All patients with abdominal pain, you need to just go ahead and oxygen them up. Just get it going. Your OPQRST. This is how you're going to get a really good history on your patient. When did it begin? What were you doing? What do you think is the cause? Oftentimes your patients know exactly what it is. And unless you ask them, they may not think to volunteer that. They got a lot on their mind, like, am I going to die? So go ahead and ask them, what do you think is the cause of this? What do you think is going on? Does anything make it better or worse? Is it worse when you move around? Does it feel better when you're still? Is there a certain position that feels better than another? Tell me what it feels like. That's what Q is. That's the quality. Describe it to me. Don't say, is it sharp pain? Yeah. Is it dull pain? Yeah. Now, tell me what it feels like. What does it radiate? Tell me, point to where it hurts. If they can point to it and localize it, what do we know about it? Is it visceral or is it parietal? Right, it's going to be parietal usually. They can point to it. Does it radiate? Does it move anywhere? On a scale of 1 to 10, with 10 being the worst you've ever felt, what is it? Is it a constant pain or is it intermittent? Does it come and go? Has it changed any? These are all the type of questions you want to get on these patients. Now, with your female patients, you're looking for some different things because most of your men are not going to be pregnant, but some of your women may be. And you need to ask these questions of any female of childbearing years, which starts at about 9 and goes up to, I don't know, 50s. I read about them sometimes. So it can be pretty old. So you're going to have to ask these questions, whether they embarrass you or not. If you've got a patient that's having a tubal pregnancy, this is a really big deal because that could burst and they could die like right in front of your eyes. So you're going to have to get this information. Ask them. These also are OPQRST questions. Are they on their cycle? Have they missed their cycle? Are they late? Are they having any bleeding, any vaginal bleeding? You have to ask them, could you be pregnant? What are they going to say? No. So in that event, if you say you've got a teenage girl, she's 16 years old, her parents are there, and if you ask her if she's pregnant, what's she's going to say? Oh, hell no, is what they're going to say. So you're going to have to make sure you separate them, and you're going to have to ask them in privacy, because they're not going to volunteer that kind of information. Are you using birth control? She's going to say, no. Is she? Could be. So make sure that you're sensitive and you can get these questions in a way that you can get the right answers. You're going to go down your sample history. What are your signs and symptoms? You're allergic to anything? What medications? Past medical history, last oral intake, events leading to the emergency. So first we're going to get history of what? Present illness. Now we're going to get past medical history. Both are very important. Say if you had a woman and she has severe abdominal pain, what would be a question you might want to ask her? Well, if it's Nick, I'm going to ask him if he's ever had his appendix out, right? Right. So for a female. Yeah. Did you copy that off the screen?
I just saw.
I want to know if she's had her tubes tied, maybe. You know, that's going to kind of narrow out some things for sure. All right, get all that kind of stuff. Geriatric note. One thing about your older patients, they very commonly will report abdominal pain, but you need to know that they very frequently have a reduced pain perception. You know, those nerve endings just aren't so good anymore, and they don't recognize that pain. We have a lot more silent heart attacks the older you get. Women have more silent heart attacks, but their decreased ability to feel pain, sometimes they're not able to pinpoint where it is. They just feel bad. In your elderly population, it's more likely that they could have a serious abdominal issue. You know, they could have a fecal impaction. You know, they could have that diverticulitis. You know, they could have, you know, strangled bowels or something. It's more likely to be life-threatening in the elderly because why? Yeah. Yeah, they're already compromised. They're 80. Gee, who wants to be 80? And they may also be compromised because of the medications they're taking. You know, just like we talked before, if you're taking blood thinners and now all of a sudden you're bleeding, you're going to have a clotting issue, right? We're going to have trouble controlling that bleeding. Same thing with your elderly patients. If they're already on blood pressure medication and they got a blood pressure of 100, now they're losing some blood, you know, from abdominal bleeding, GI bleeding, then it's going to be much worse because of that. Your physical exam, make sure you're inspecting and palpating. Inspecting means what? We're looking. So you've got to look at it. You're looking for distension. Is the abdomen distended? Is there any discoloration? Is there anything protruding? What would be something that might be protruding?
Hernia.
Yeah, they might have a hernia that you can see. If it's strangling the bowels, you know, that can be a big problem. You want to palpate. You're going to use your fingertips. When you're palpating the abdomen, you want to make sure you palpate the painful area last. If you hit that part first, are you going to be able to palpate the rest? Oh, heck no. You're not touching me. You're looking for rigidity. Normally the abdomen should be soft and non-tender. If it's rigid, what are we thinking of? Yeah, peritonitis, something that's irritating the line of the stomach where they're going to want to curl up in a ball because it hurts so bad. Vital signs, if you've got a patient with abdominal pain, then you're going to consider them to be unstable until proven otherwise. So you're going to check their vital signs every 5 minutes. You're checking the blood pressure. If they've got an acute GI bleed, they're losing a lot of blood, their blood pressure is going to drop. They're going to become tachycardic. Their respiratory rate's going to pick up. Look at their skin signs. Are they perfusing or not? You know, check a capillary refill. What's that look like? Check their mental status. If they're not perfusing well, what's their mental status going to be like? That's right. ABCs, put these patients on oxygen. Put them in the position of comfort. If they've got abdominal pain, what's going to be their position probably? Yeah, they're going to be probably in the recovery position. They're going to be pulling their knees up. They're going to be most comfortable that way. 89-year-old female with a history of diabetes, hypertension, and gallstones is complaining of nausea and dizziness about 20 minutes after eating. What do you think about for her? Well, she's 89. What all could be going on? She's nauseated, she's dizzy, 20 minutes after eating. You're going to think gallbladder first because of this, but could she be having a heart attack and she just happened to have just eaten 20 minutes ago? Sure. So things are not necessarily connected. Is this an abdominal emergency, a diabetic emergency, or a cardiac emergency? She's dizzy, right? Yeah. Now, what might you think it's not a diabetic emergency?
She just said it.
Yeah, she just ate, so it's probably not hypoglycemia, right? How will you know? What will tell you if it's cardiac or not? Hypertension could be that. One thing about diabetes it can cause silent heart attacks because diabetics very frequently have compromised nervous systems. They don't feel pain. They don't perceive pain like other people do. So they may not even feel a heart attack. So what's the treatment going to be for this patient? Oxygen, how are you going to position them? Position of comfort, whatever that is. Oxygen, sure. Let's see. Abdominal complaints can be serious. You're going to treat them all like they're serious. Diagnosis will be extremely difficult. You may come up with some differential diagnoses, but you're not going to pinpoint it most likely. You're going to have to do a good history and physical exam. Quickly identify anything that could kill your patient. If they have an aneurysm, if you feel a pulsating mass, if you suspect internal bleeding for whatever reason, if they're shocking, all those things can kill your patient. Airway, oxygen, position, transport. And don't forget your BSI. Assessment and management always take a high priority. It doesn't matter the cause, your treatment's going to be the same. You just got to recognize if it could be something serious and then move along quickly. You're going to need to know the characteristics of the different disorders. What's going to happen on registry, they're going to give you a patient and they're going to say an acute onset of pain. They can point to it. It hurts right here. Or, they're going to give you something where you should be able to get a good differential diagnosis based on what they tell you. And if you don't know what the signs and symptoms are of each different disorder, then you're not going to pick up on it. Go to that one. What are 5 signs and symptoms of abdominal distress? Nausea, vomiting, those are surefire. Nausea, vomiting, what else? Yeah, abdominal pain, positional pain, what? Back pain, pulsating mass, diarrhea. What's the difference between visceral pain and parietal pain? Visceral is what? Dull. Parietal is going to be sharp. Yeah, usually. Okay, yeah, we're talking that. Good. Y'all need to know this because you may see it again. What's urgent care? Or already said that. Hey guys, look, we did it. It's 8:45. No, we can't leave. We can't leave. It's just too early. Okay, on Tuesday, we're covering, I think, 2 chapters. Is that right? We're doing 3 again. Probably just 2. This is the worst of it, okay? After this, things should get better. No class on Wednesday, remember? So I'll just see you one time next week. I'll miss you. I'm so used to seeing you very frequently.
I will be here Tuesday.
No to Tuesday. Who else? Reed, you won't be here Tuesday? You won't be here Tuesday? We may have a party. You're not going to be here.
I'm going to have my own party.
Pop quiz party, yeah, you probably will. Probably a lot more fun. Well, y'all be careful wherever you go.
Are you just going to email me and let me know, or do we just figure this out?
Email and let you know what?
I don't know, like when I need to do makeup anything. I know the KED thing I'll make up on my lab.
Yeah, we'll do that on the lab night. We just need to meet and talk.
Okay.
So,
Just any time?
so you won't be here next week. Well, I don't like to meet right before class because I usually have so many things going on.
That's fine.
Can you come in during the day?
Yeah, I emailed you earlier this morning when I was at work and asked if you wanted me to meet you like earlier this morning or something like that, but
Yeah, I was in meetings this morning, then I went home and I came back to say I've been in meetings most of the day. Did I answer you back?
you answered me back one time. I couldn't remember.
I bet I did. I can't
Yeah,
remember
we'll
what I
just,
said though.
I'll just, I guess, email you.
I'll be back, after vacation, I'll be back Monday. I'm here all day Monday.
Yeah, I'll
I'm
just
here
come,
Tuesday.
so I'll email you or just come
Yeah,
down
yeah,
here
yeah.
and
Let me
come
know
to your
what's
office.
convenient for you. Like you work or anything,
Yes,
or you
ma'am.
just hang around.
I work.
Okay.
Which station is station number 2 for the ambulance?
I think that's Auburn.
That's the one over there, like on Chickern on into Sanford. Right there.
Yeah, yeah. You
Awesome.
going over there?
Yep, I got all night tomorrow night, and then I've got Sunday from 8 to 8. So I got a day off in the
Okay.
middle.
That'll be fun for you.
Hopefully I get to see some crazy stuff.
I hope
That's
so.
why I signed up for a Friday night.